Today on the 229 podcast.
I would love it if our clinical teams went about the business of taking care of patients and never had to touch a computer again.
My name is Bill Russell. I'm a former health system CIO and creator of This Week Health, where our mission is to transform healthcare one connection at a time. Welcome to the 229 podcast, where we continue the conversations happening at our events with the leaders who are shaping healthcare. Let's jump into today's conversation. All right, it's the 229 podcast, and today I am joined by Matt Sullivan, CMIO for Advocate. And 229 podcast is about continuing the conversations we start at the 229 project meetings. And Matt, you guys have such a great group with the CMIOs. It's been fun to see the conversations that you guys have had over the years and the group of CMIOs. I remember the first meeting we had, there's maybe 6 of us in a room. And you guys were like, hey, this was really good. And I'm like, there's only 6 of us in the room. And like, no, this was really good. Let's do this again. And it's really grown from there. And a lot of good CMIO conversations have come as a result. Hey, welcome to the show, by the way.
Yeah, thanks for having me. Good morning.
What's new in your world? CMIO for Advocate. I mean, at one point you were down at Atrium, then it's Advocate Aurora and Atrium come together. How does the job change with scale? I mean, it's huge.
Boy, that's a great question. I was hoping to ask you the same and maybe get some insight to sort of out that the reality is a ton of our time is spent trying to figure out how to scale. I mean, here we are at 11 o'clock this morning, and already 3 times today, I've had conversations, have meetings, and closed the meetings, and then gone back into simple conversations around what we just talked about, seem to be coming at it from 2 different vantage points. How do we bring that together? And then how do we plan for additional acquisition, right? Because the game is not over, right? I think we're seeing that across healthcare. We're seeing mergers and acquisitions, banding together larger groups as a way of sustaining us in a very challenging business environment where margins are low, and we're trying to capitalize on all the things that we know happen when groups come together, whether that's supply chain, contracting, et cetera. It's an ongoing problem to figure out how to take different groups that maybe come at it culturally from the same, good spot in your heart, but tactically come at it from a different perspective. Which things do you keep from one versus the other? And then how do you bring them together so that the marriage of the 2 is actually effective and hopefully, if we do it right, more effective than either of the 2 that you had in the past? And so it's a great question. I'm fortunate that their organization is really large. And so I have a fairly large CMIO team of smart folks that at one point have all been great docs and then meandered their way into informatics in the same way that most CMIOs landed there, at least in its inception. So it's a challenge is the answer. The singular answer is it's a challenge, but it is part of the work that's required in order to get us where we need to be.
It's interesting. We had similar problem sets in that at St. Joe's, I'm thinking culturally, I had West Texas and Southern California. If you can imagine 2 culturally different areas. And I remember having some of these meetings where, essentially physicians were telling me we don't practice medicine the same way they do in Southern California. And I don't doubt that some of that is true. That there are distinct regional kind of things and approaches, but they were very difficult meetings because you're trying to drive quality across the entire system. And what I found to be the project which ended up creating the most momentum in that direction of quality across the entire system was the EHR implementation. Like, we consolidated and went to a single EHR, and we had to make those decisions across, but it didn't make those decisions any less difficult.
Yeah, I think the decisions will always be difficult. And I actually completely agree with you. There are always the physician groups or even nursing groups that say, hey, what we've got is a little different over here than what you've got. So I think the issue for us initially is to ground on what's important. And so I think that is the beauty of our senior leadership has come together and said, look, here's the strategic drivers for Advocate Health. It's not a holding company of a bunch of disparate little hospitals that do their own thing. It's truly a singular organization with singular focus. Here are the strategic principles. Now you execute them. Now, that transition between strategy, tactics, and execution is always challenging. It doesn't matter what size of hospital you're working at or healthcare system, but to have that drive from the top that links everybody together, you can start those conversations that are going to be challenging and say, look, all of us are coming at this from the idea that we're going to rewire ourselves in a way that drives this outcome with these quality metrics. And we have to be mindful of our mission. And at Advocate Health, the mission of sort of serving all is really huge. So we're a for all company where we have to tackle things that work both in downtown Chicago and rural Georgia. And that is like your example. Although in Texas, I think they probably would consider themselves to be unique. And
they, they made it clear. They made it clear every time I flew in there. It's like, you're from California. I'm like, I'm not even from California. I grew up in Pennsylvania. I lived 20 years in Missouri. I'm like Midwest. And that's why they kept sending me. They're like, yeah, you speak their language. I'm like, St. Louis and Lubbock are very different places.
Different animals. That's the case. And it's that shared understanding that we are, in fact, different people, different cultures, but we're driven to the same mission. And so once you all agree and you start the meetings, look, we have to come together and this is our goal. We got to achieve this. How are we doing it now? What's really different? Because there are differences and then there's real differences. And when you get down to it, the way you practice medicine isn't substantially different from one place to the other. Each medical case, each patient is different, but the drive, the focus, the execution. And I learned that sort of in my own practice over a series of years, moving from an academic center to working in the community, to going to freestanding EDs, to driving pretty far out, to understand that the patients that I was seeing when I was practicing, as it turns out, those communities aren't different. When you have chest pain, you have chest pain. When you have abdominal pain, you have abdominal pain.
But where do you draw a hard line? And I realize in your role in the CIO role, it's rare that we draw hard lines. Where do you draw a hard line and say, look, we're going to do the same workflow. It doesn't matter where you show up. It's the same workflow. We're going to document the same way because we have to document the same way. It's driven regulatory and those. Where do you draw the line and say, look, there's no discussion here. Up here, we can talk about the variability, but below here, let's try to drive systemness if we can.
Well, we drive systemness by saying, here are the lines. And I think the lines are very clear and they're actually pretty similar regardless of your size. So the lines for cyber, right? We're not going to let you do this. These companies, these software programs, these tool sets are dangerous. So no. Okay. And that's one of the very few.
So they're not copying, pasting from Epic and putting it into ChatGPT and doing that stuff.
You can use the brand names of whatever. It's that principle that we're saying, hey, time out. You can't do that. The safeguards, although they say they're there, they may not actually be there. And maybe that's because we don't understand it very well yet. Maybe it's because that technology is not fully developed yet, or maybe there's a real risk, right? Either way, there's a hard line there. And then the rest of the lines, I would say, are gray, dotted and dark gray. Because when you come at it with the approach of, hey, here's our goal, and let's use our EMR vendor as an example. If the EMR vendor hands you a solution set that says, look, it's going to work like a foundational approach, and it's going to get you all the things you need, the stars and the magic, and it turns out that workflow is really efficient and it drives the work in a better way for the downstream clinician, whether that's a doctor or a nurse or a physical therapist, those folks see that pretty quickly. I mean, that, to be really frank, that is the beauty of working in medicine. These systematized issues happen probably all over the world in all sorts of industries. But in medicine, we have people that are driven for patient care and generally are very smart. And so they see it very quickly and they say, oh, yeah, that's going to be faster than the stuff we've been working on. And that is a win-win. I'm not running into many things these days where the vendor comes in and says, look what we've got. And I have to go sell, shit on a shingle, so to speak. It doesn't happen very often anymore. It used to be the case, right? Hey, look what we've got. People go, oh, that's horrible. You mean I have to type all this stuff in and then I have to go to this other place and then why are you having me do that? Can't we have somebody else do that? Yeah. We're starting to that inflection point change to where the vendors are making the work better and making the outcomes better. And some of that is fueled by AI through things like, ambient dictation, where some people love it. They walk out and they go, oh my gosh, look at this. Did my whole note for me. And then there's always people that have a little bit more, OCD tendency and they want to review the whole thing, rearrange it. That's fine too. Both of those scenarios were far less than somebody typing stuff in.
AI is an interesting conversation. You and I have had some really good conversations around AI, and you guys believe that there's a future for AI in medicine. And I specifically, we've talked in the past about the stuff you're doing with the hospitals down in the Southeast and with computer vision and whatnot. I mean, why are you confident in a future that has AI embedded in the care setting?
So I'm going to frame it using the computer vision a little bit. For a long time, I would say to people, like really close friends, look, if you're really sick, you're going to wake up one day in the middle of the night and I'm going to be sitting in your hospital room, right? Because I've worked at lots of hospitals at night and I know that like there's not everybody's watching all the time.
And did that comfort them, or were they a little scared?
Frightened to death, and that's probably fair. But the idea that someone else is watching over you all the time, that has some knowledge of what should be happening, what shouldn't be happening, in a sense of trying to wrap your brain and your skill set around someone that you really love, is why people don't just say, like, your wife is not going to go, hey, Bill, good luck with your, cardiac bypass. Let me know when you get discharged. I'll swing by and pick you up. Like, that's probably not the way she's going to operate.
Let's hope.
Knowing her, I'm pretty certain that she's going to be at the hospital. And we see patients and families who are exhausted. They've been, in some cases, depending on where you are, sleeping in a recliner and eating food out of a cafeteria that's not sleeping in their own bed. It's not their own stuff. And they're discombobulated, which doesn't help the patient. When we've put ambient listening devices and ambient, synthetic, like the whole package around that, we're of course worried. People are like, whoa, Big Brother's watching the whole time. That isn't what we're getting. We're getting that human connection to say, hey, I feel good about going home and taking care of the dog while my dad is sitting in the hospital, knowing that somebody is there. And if he says, help, someone will come on that camera and someone will come on the TV screen and be right there for him. Because pushing the call bell button hasn't been working for us, but this is a much better situation. And so that's why I'm bullish on it. That's why I think there's a value there. Now,
the alternative would be if you could put a physician or a nurse in my room, 724, 365, that would be my preference. We just can't do that.
We've seen that in the medical literature that lots of specialty care is primarily driven off having that specialty highly trained nurse at the bedside continuously in like a neuro ICU versus regular floor. The outcome for the patient is different. The doctor can be the same, the CT scan's the same, the pathophysiologic process is the same, but the continuous expertise that is at the bedside seems to drive people to better outcomes. If you could embed that in every patient's care across a larger system, then you really could maybe change the game. Now, that has nothing to do with efficiency. That has nothing to do with sort of cute or high-tech fun. Like, we all love high-tech fun. But that's really around making sure that we have somebody watching. And then the second component is there some AI that can not only watch, but watch with them for specific things relative to the disease process. And so I think about what the future might look like for respiratory disease. And we'll just pick an example. There's lots of examples, but someone's having trouble breathing and there's a certain rate at which you breathe, and there's some difficulty, and there's a inhale component and an exhale component. And some of that stuff we check off, like once every 8 hours, we're going to check your respiratory rate. You're going to check your pulse ox, maybe continuously. But I don't know of anybody that's looking at respirations minute by minute, second by second, breath by breath, measuring inhale, exhale, and trying to figure out what the trend line looks like. Is somebody getting better? Is somebody getting worse? And if we know somebody's getting worse, can we identify that slightly earlier than we previously have been able to do? And does that actually change their outcome? And in order to do that, we've got to intervene with something. And I'll say something like a breathing treatment, just to sort of be generic about it. But if your respirations and your respiratory function as viewed by an AI agent who can sit there 24/7, 365 and watch, as it goes down slightly, if we intervene early and it flattens or improves, and we show then people get out of the hospital a little bit faster, don't have as many problems, don't need as many treatments, lots of outcomes, you wrap your head around the possibilities. But I think that's where it's helpful.
these are significant organizational change management projects. I mean, they're significant IT projects. You're going into all these rooms and you're putting these things in and whatnot. They're significant clinical projects and workflow projects. But culturally, there was a strike. I think it was in California where the nurses went on strike and said, no AI in our environment. And there's a fear that it would do something. It would, take away their work, which we have such a nurse shortage. I can't imagine why that would be a concern, but that was one of their concerns. And people don't know what to make of AI yet, including nurses and some physicians and others within the health system. How do you say, hey, let's try this out? Let's see it. Let's see what's going on.
This was my 8 o'clock call this morning, and it was with an IT person, right? And a long-standing IT person who I've known for many years, great guy. And we were trying to work on something like we always have been, right? And now that we have AI in the mix, I had created an agentic agent to help with some of that work. But the person was so stuck in the old school ways, not in a bad way, like, hey, I want this regimented, I want this in the right format. I want to make sure we have all the data so that as we move from place to place across large organization that we know we can just query and it'll come back. And I said, just throw it all in the big folder, point the agent at it, and it'll just tell me what happened last month. And it'll just, no, ignore that. Tell me what happened last month, put it in a chart, and then put all the dumb stuff at the bottom, put all the really cool stuff at the top. And he just couldn't wrap his mind around it. And it took me 10 minutes to say, it actually will work that way. And then the next question, well, don't we have to then change everything to be in Excel? And the answer is no. We can just throw it in as Word documents. Throw it as whatever you throw in the SharePoint folder, point that there. It'll look through it all and it'll help. You want to change it around? You want to alphabetize it? Okay. You want to look at 25 versus 24? It'll do that for you. It took me 10 minutes and he was like, oh gosh, I'm sorry. I get it now. That's my conversation with a very talented IT person that's been in our healthcare system for 20 years. So the cultural change you're talking about is massive. When you take that down to the level of the nurse and you say, hey, AI is coming and we're going to use it for everything that you do, and they get frightened, then you've done the change management wrong. If I said to a nurse, AI is coming and we're going to try to get it to do everything that you do, and we're going to try to get it so that you can just walk around and do the things that make you as a nurse feel good in the old way of caring for patients, so that you don't have to be a slave to the computer. You don't have to walk around and just constantly document on a device, that you can just do the things that you know are good for patients, and that somebody is taking care of all the documentation for you, and someone's double checking the things that are oftentimes a problem for you, and providing you a safety net that you know exists, and allowing you to reach out and quickly get help if you need it. And then all of a sudden people go, oh yeah, I want to work at that place. And so when we wired up our entire hospital, it was amazing to hear the nurse leadership say, this was new for us. This was a challenge for us. And we were a little skittish because we always have a nursing shortage. We got all these travelers that we've got, and then we got all these people leaving, and have a single nurse leave in the first year. Everybody stayed. And I was sitting in this, you're rounding with you're in a suit, you're rounding with a bunch of leaders, and you sit there and go, oh my, did she just say that? And the answer is, people love it because it gets them back to what they wanted to do in the field of medicine and away from the stuff that has plagued us for the last 25 years as we have brought on technology. So I'm seeing the pendulum swing from, oh my gosh, technology is killing us. It's a documentation and billing system, and we're making, 50% of our work is there, maybe more. Now back to maybe toward the middle. I won't say quite in the middle yet, because I'm really hoping to have more room there. But I would love it if our clinical teams went about the business of taking care of patients and never had to touch a computer again. Will we ever get there? Probably not.
Yeah. I mean, that's the challenge with all of these projects, is the getting the buy-in from people. It's like, hey, we're going to try this. Let's see where it goes. Advocates, what? How many hospitals now? Is it 40, 50?
I think it's 7,000 or 8,000. I can't keep track of it, Bill. I think it's,
They tell you, hey, can you go up to this hospital? And you're like, I didn't know we had a hospital there. That's going to be fun.
It keeps changing, and it depends on what you're looking at. We have a ton of Connect sites too through our Epic Connect program that we support. And so the work that we do on the IT team that Bobby leads is like, it's massive. It goes to places that we don't actually have physical footprints, that we own the buildings, but we manage their IT. And that's pretty fascinating to think through.
I'm sitting here. I used one of the tools to look up Matt Sullivan, the CMIO Advocate Health. I didn't know you spent time at Hahnemann in Philly.
Yeah, that's where I trained.
That's where you trained. Wow. And I didn't realize you spent time in Philly. Is that where you started your career?
Yeah, I went to medical school in Philly. It was just 4 years.
Wow.
And then I came immediately down to Charlotte. So I'm a lifer here in Charlotte. I was a medical student. I did my residency here at Carolinas Medical Center, did a research fellowship at Carolinas Medical Center, was on faculty for 15 years, and then sort of meandered my way into the adminisphere with quality and evidence-based care as we were starting to build order sets and build things in the original EMR to sort of help us do better. And so I did that for 3 or 4 years, and then that just naturally sucked me into the informatics roles. So
Your career's not the norm, as you know. I mean, CIO means career is over. CMIO probably means something like that. And you've been in that role for quite some time, even through mergers and acquisitions and other things.
yeah, I mean, I was a CMIO, or I was an associate CMIO with Brent Lambert for a long time. And we've been banging around through a couple of EMRs and probably now on 6 acquisitions and mergers. And so it's kind of an interesting survival story.
The first time I met you, I don't know, we ended up sitting at a table together. It was you and your bride, who is phenomenal, also works at Advocate, and my daughter and myself, and there was somebody else there. I forget who it was, but we were at that table that laughed all night, and everybody else kept looking over, going, "What?" Because you guys just
there was like 3 boring tables, and then we were just
oh my gosh.
great.
Because you guys were telling the stories, you were sharing pictures of how you got together and all that. It was fantastic. And then the next time I saw you was at the Scottsdale Institute, and it was like a complete role reversal because you were going through and I forget, like either your clinicals or your rev cycle had to be switched. I forget which one it was, but you were right in the middle of it and you were not home. So you were trying to troubleshoot that stuff over the phone.
I was desperately out of fish, out of water, and exhausted. So I think we lived through all that stuff. But you know, a very important point, Bill, which is around how do you live and work in the environment that you're in? You know, I'm clearly not the smartest guy, as you know. And like, so why is it that you can be successful in an organization? And I think part of it is that you've got to be willing to tell the stories, good and bad. Like, we've had some amazingly fascinating mistakes, and you have to be willing to sort of talk about those and learn from those and have a little bit of fun. Like, we had a major screw up yesterday, and I called someone. I was like, "Really? Is this what happened?" And they said, "Oh my God, I didn't even know." And then it was back and forth, and it was a funny conversation. I mean, we were all irritated, but what are you going to do? Like, the die is cast, clean up the mess, and then move on and have a little bit of fun with it, have a little bit of humility, and just try to get the right work done at the right time.
I tell you, you did dodge a bullet, and we've talked about this as well. The bullet you dodged was I did interview for the Atrium CIO position, and I don't know if you were in the room for my interview or not. There was 5 people in the room, and I did not get that job. So you ended up with Andy Crowder, and I think that was the right decision. Like, if they had asked me between me and Andy who should be the CIO, I would have said Andy. He has a better temperament for being a CIO.
We would have survived, but it would have been rough, I think.
It would have been rough. I can only imagine. What are you looking for these days when you go to hire somebody? I mean, does all this change? I mean, Epic UGM just rolled out a truckload of AI capabilities and whatnot. The amount of change that clinicians have to deal with these days, the amount of change that we have to deal with in IT is pretty constant, and I don't know if the pace is quickening. It feels like it's quickening. Is that one of the key qualities you're looking for now? Is somebody that can adapt to change fairly quickly?
The IQ, EQ balance is always in the mix, and the sort of that adaptability and ability to move and roll quickly. And again, I think the pace of change over the last 3 years has been really much faster than it was. Some of that is AI driven, and some of that is sort of venture capital into healthcare with lots of opportunities for different vendors, different solutions. And everything from bolt-ons to completely freestanding solutions that rip and replace what you already exist in, like your existing stack. And so somebody has to go through and evaluate those things. And also you have to be willing to sort of step out there and say, hey, we haven't looked at this one and we're not going to. And here's why. And so there's a little bit of the ability to manage those conversations, particularly when they come from operational leaders that are smart physicians. And if they go to a conference and they're sold on something and they come back, hey, look at this. I want you guys to look at this. Sometimes you have to look at those things because it's politically the right thing to do. But sometimes you look at those solutions and you look and you think, this is not going to work in our current environment. And here are the 5 reasons why. And the ability to take that, understand where that sits in the strategic and tactical stack, and then pull that apart, have a couple of quick conversations, make sure you're on the right footing, go back to that senior medical leader and say, I don't want to look at this. It's not because I don't want to or I won't do it. I will if you want me to. But here are the things that I think are going to make it difficult for this to be successful in our environment. Tell me where I'm wrong. And then they say, I don't know anything about this. It just looked cool. Forget about it. Or they come back or they come back and they say, actually, did you see this part? And this is where we don't have that. And this is the part that I want. And then you have to be able to go back and sort of dig in and think, okay, is this the company to do that? Or are there other companies that do just that part? Do we build it internally? And that's the conversation that we're having with AI, right? How much do you take off the shelf? How much do you partner with people to modify and take a startup and do something new and different and help them and help yourself at the same time? And then how much do you just say, forget it, we're going to build it internally because we have the tools and capabilities and scientists to do that. Then that's our struggle. And I think I'm very lucky because I do have people like Andy Crowder, Bobby, and others on my team that are like working at all this and are pretty good at it, I think. And I have scale. And so much that if it was me alone, I don't know that I could do it alone. So I have a sort of soft spot when other CMOs who are one in a group, like there's only one of me at my hospital system.
And I've been surprised how many of these conversations where I go, well, how does that align to your strategy? And they'll go, well, our strategy's kind of nebulous and we kind of tack things on here and we tack things on here. And I sort of look at that and I'm going, these are billion-dollar organizations that don't have a clear roadmap. And when the clear roadmap is not set, which is the number one thing that leadership does for the people downstream, is set the direction. And when they do that, it becomes clear what to say yes to and what to say no to. Because it is hard to say no to things in healthcare. But if it's not within the strategy, that's like the backstop to say, look, we're heading in this direction. This is cool, but that doesn't get us in that direction. But
right.
So let's keep looking at things in this direction because that's where they told us we should go.
Yeah. And sometimes that's hard because the cool stuff is like,
it's cool.
Cool. Like, so I've got cool stuff. It's hard. And I think when we first started talking and met you many years ago, at the time, my joke was like the role of the CMIO is to say no. Because it was always like, I wanted the EMR to do this. Well, it doesn't do that. It doesn't make breakfast for you. Okay, well, can it make toast? No. Can it give me coffee? No. Like, that was my funny little quip. Now, like, the funny thing is, yeah, that's cool, but we can't do it. Because we're doing this cool thing. Like that, that's cool, but this is more cool. It's this very strange interplay between the operators and the technology and the strategy.
Well, and the other thing that's hard is when you have scale, you can't use we don't have funds for that. But I mean, you will say that because it's like, look, it's not unlimited funds, but we've chosen to invest in X or Y. Speaking of which, you were up at UGM. Yes, because you blew me off up at UGM. That's right. You were there.
You were coming back from an international vacation and you looked tired. So I left.
I was very tired. What's your takeaway from UGM? I mean, we have Emmy, we have Penny, we have Comet, we have Cosmos, along with a whole host of other things. I mean, plus your team presented a ton up there. I mean, Advocate was all over the place.
Well, it's one, scale, and two, a great team of people that does great work. And so I love the fact that they showcase that. We learned a lot internally still, even though it's a marriage of years now. We're bringing people from multiple areas of the company together and they meet together in 3D and you learn a little bit there. It's just part of the deal, which is fun. I really enjoyed that part. Donner, Blitzen, and all the cute names that are, applied to all these little components. It's clear that Epic is making an investment in AI with lots of targets. The question is, it's not a question. Invariably, they will do incredibly well at a number of those targets, and they won't do very well at a couple. And so the secret sauce is to try to figure out, how does our strategy line up and pair with the things that we think they're not going to do very well at, so that we can continue to accelerate, maybe learn the ropes, maybe help them understand better, so that in the end, their final product is really good while we keep iterating on the front. And that is a little costly, but if we can justify the ROI and the investment of time and energy into it, and really sort of be on the leading edge in just a couple of spaces that'll allow us to focus,
Yeah.
and it'll allow Epic to do some of the other bigger tasks that we know they're going to be good at. Some of the back end stuff, they're really going to be good at that stuff. And we know that they've been solid there.
Well, we're getting close to the end of our time. And since you are a physician and you watch that, I talked to a physician immediately following the presentation. And he asked me, what'd you think? I said, when I saw how they're using Cosmos at the point of care to like real time sort of act as a partner to the physician to say, hey, look at this. Have you thought about this? Have you ordered this test? Because, you said I look tired coming back from international. Some of the doctors I see look very tired at the end of a long day. And I would like to know that they have, somebody looking over their shoulder saying, hey, make sure you order that test for Bill too, as well. And I said to him, I'm like, I think in a year or two, I'm going to only see doctors that are using Cosmos, because that gives me an added feeling of, I don't know, security, whatever the feeling is that makes me feel better about that I'm being cared for. And it's sort of the opposite of what we hear about AI. It's like, oh, we're worried about AI is going to hallucinate and whatever. And I'm sitting there going, look, I trust Epic. I trust 300 million patients in there. The amount of data they can throw at this, I'm like, I want that second opinion. I want that second set of eyes, if you will.
I agree with you. I think you and I are technically aligned to think through that and think this could be doable. Also agree with you that we've seen in the literature and the science that where people have studied this, that when we put AI alone or a physician alone, they're going to underperform AI and a physician. And so 300 million patients, and 50 million of them have yellow hats. And that's what you want to have as your oversight. But there's more to you than just the yellow hat.
There, right? Absolutely.
You're going to need that person, tired or not. We've been tired for a long time, but tired you're going to need them to use the actual human brain to analyze. And there may be, let's just say you're a tired physician at the end of the day and you miss something. Okay, great. There's a safety net, there's an oversight, and you go, oh yeah, I should order that for Bill. But I'm worried on the flip side of the change management equation. What if 9 times or 90 times out of 100, it's just an irritation? And every time we're asking a clinician to click, no, justify that. Bill has a pink shirt and a yellow hat. That's different. Submit. Like, we don't want that. And we've seen that through alerting.
Yeah. Absolutely.
I think we're going to be in that same swinging of the pendulum. And my hope is that it will land where you and I want it to land, which is a non-intrusive safety net oversight that allows that depth of knowledge of 300, soon 500 million patients to be right there at the fingertips of the clinician, so that they can use it exactly when it's appropriate to be used.
I mean, well, and that is one of the things I spent a lot of time reading about, was just this whole idea of context and drift. It turns out that AI models perform better if you don't dump 300 million patient records into it. It performs better if I'm seeing Bill and I just dump in that subset of yellow hat wearing patients instead of 300 million, because it's all the rest of it is noise, essentially.
So how do we split so we get the yellow hat, pink shirt people in, and the AI can focus on just that swath to really give the right answers?
Right.
But then there's the issue of Bill never wears a pink shirt, just today. And so that there's components of this that, I mean, when you really analyze what a well-trained physician does at the bedside, it's fascinating to think about the synthesis and all the work that's gone into preparing people. And yet mistakes are made. We know that. We've seen that in the literature. You can talk about the quadruple aim and how we should be hitting it all the time, and we don't. We know that. So there's power here. How we apply that power is, I think, the secret sauce to making healthcare better, making our teams more efficient, and making people feel like when they go to work, whether they're on the doctor side of the house or the patient side of the house, that it's going to be the best that we can deliver. And that's why I go to work every day.
Yeah, absolutely. Matt, it's always great to catch up with you. Love to hear what's top of mind for you guys and where you're going. Thanks for your time.
Thanks, Bill.
Thanks for listening to the 229 podcast. The best conversations don't end when the event does. They continue here with our community of healthcare leaders. Join us by subscribing at thisweekhealth.com/subscribe. If you have a conversation that's too good not to share, reach out. Also, check out our events on the 229project.com website. Share this episode with a peer. It's how we grow our network, increase our collective knowledge, and transform healthcare together. Thanks for listening. That's all for now.